Okay, so this should be a stimulate that Dr. J will going to introduce the vice president of the Emirate Society. Originally, Abdullah is yours. I'm okay. I will introduce Dr. Abdullah. You know, congratulations, Dr. J, that this is the first time to have to be with you as the professor of cardiology and the chairman of the Emirate Society. And this is the first collaboration between the CVREP and the Emirate Society. I hope in the future we have more collaborations in all fields of cardiology. It's my honor to introduce my friend and most of the Egyptian colleagues. Just with Abdullah yesterday in the hypertension MENA with the CVREP. He's did a great job in chairing the sessions. Dr. Abdullah, professor of medicine and chairman of the scientific committee, EMA, editor-in-chief of New England Journal of Medicine, and vice president of the Emirate Society of Cardiology, is going to speak about the important topic, and he needs, I think, a lot of questions about this evolution of the CCS, which is, I mean, nowadays a new terminology, chronic coronary syndrome, towards personalized management approach. Abdullah, floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm really honored and pleased to have our president, Dr. Juwairiya, first female leading this Emirate Cardiac Society, and really everyone is proud of this. And of course, to collaborate with Muhammad Subhi, my dear friend, on his institution and his organization. So in this few minutes, I'll try to discuss the guidelines optimizing management of the CCS, or whatever you want to call it, and with some cases. I want to start with this case here, which I think is our daily things we see. A patient of female with all the risk factors. That's why the prevalence of cardiovascular disease in our region, I think, is higher than the world 2 times, based on our latest meta-analysis we published 2020. We are 10.2% compared to the world 4%. And because of these risk factors, happens early in life of our patients. So this patient basically had already RCA and drug-eluting stent, and coming with with angina, angina, which class 3, which tells you really something is going on and maybe you need more attention. And you look at the patient vitals, the patient's discussion of hypertension, leading risk factors. It's not optimum, and the patient may be of all these risk factors, and LDL may be not optimal, and also there is diabetes. If you look at the medication, patient only may be on beta blocker for angina and CCB, and where the rest of the medication, and this patient already had intervention. Was that appropriate or not? And we receive these kind of patients, and there are many reasons we maybe prematurely intervene before we optimize their medication. And another case here already had ACS and stabilized and had cabbage. And again, if you look at the patient medication and for angina, you can see already ranolazine, which is the second line or third line, you can call it. Beta blocker is here, and of course there are things are missing here. And you ask yourself, this patient with heart failure, is this ranolazine is appropriate or not? So sometimes we need to understand our patients' characteristics and the medications before we think about what to do. So I think this has already been discussed. I think we should be aware of this. Cardiac causes of chest pain, non-cardiac, and cardiac ischemia, and nicely, beautifully mentioned by our colleague previously. And these are all the mechanism underlying the angina, epicardial and microcirculation, or combination together. And this is the challenge, really. It's not easy. That's why the maybe coronary angiography is not itself give you the idea what's happening if you don't know if you don't consider from epicardial to the cellular level. 2013 guidelines is basically tells us about angina relief and event prevention. So when we manage patient with angina, we try to relieve their symptoms, quality of life. And of course, there are some medication to also improve the mortality. And of course, these are on your right side. So we see here the patients with we start nitrate, but the problem with nitrate, as all of we know, is the side effects and the tolerance, and the beta blocker, of course, is there. And again, we have many issues with the beta blockers and CCBs. And, the second line we so-called, which is, if we are, sometimes we forget about them, and it should be really based on the patient characteristics and tailoring to the patient, because we are not dealing with the population, we're dealing with the patient, as you can see, as you saw already with the cases I presented. So in 2013, combined pharmacological and with revascularization is to be there, but not prematurely we revascularized. And as Dr. Subhi mentioned, the schema trial and many others tell us, we should not jump into the invasive unless really we've done our job and tailored our patients' medications appropriately. So, you can see, I've just say it again, the combinations, first line, second line, and the importance of a medication which is focus of today is trimethoprim, as known as another name for it, is 35 milligram twice a day. If you combine it with a beta blocker, you work at the epicardial and cellular level, you get the advantage. And of course, that was the management in 2013. We tried just manage angina, but I think what happened in 2019 is not only that, you need to diagnose it. I think because sometimes if you don't diagnose the angina, you might give the patient wrong medication. So, and that's, you can see the prevalence of the angina is changed, I think, and that's why maybe if you look at the studies, tells us only 15%, up to 15% have this typical angina, which we know central and worse with with effort and relieves with rest, and so these are the characteristics. You don't find it only find 15% on all these studies. Which really it's tell us, we need to be more kind of specific in our questions with our patients and not just take things. And of course, we all know about cascade of ischemia. This is the things, we wait until the patient get angina, but as Dr. Muhammad Subhi and Dr. Juwairiya, I think everyone agree here, we need to look for the ischemia and things happening at the early as perfusion abnormality, not just to wait until we get the ECG changes. And that's why I say patients ECG always, we can see in our clinic, they are normal. And that's why we say patient has no problem, but that's not the issue. Even the stress ECG, you can see, is being downgraded because of this. And there's many patients being missed because of that. So non-invasive investigation is there. And of course, we have to be excellent in these procedures to diagnose our patient as early as possible, like calcium scoring and CT usage at the low to intermediate probability of ischemic heart disease, compared to the moderate to high, where we go for something like nuclear and or coronary angiography itself. And why is called syndrome? Because it is syndrome because you don't know, your patient, you never is stable. One day stable, tomorrow is having heart attack, next day having heart failure. So symptoms of shortness of breath and chest pain, it should be in these things based on, of course, characteristics of the patient. The patient, I've already showed you the two cases, both of them got multiple risk factors. So these patients, unless you control their risk factor, then always they are at risk of having events. And this is very important when we diagnose patient with the CCS, is to be evaluated at least 4 times a year for risk stratification and assessment their treatment and improving their treatment. Otherwise, patient, you just overlook their management, and you might maybe intervene wrongly, or maybe intervene very late. And so these are telling us that all the anti-anginals, there's no evidence for improving mortality, and there's no evidence for the beta blocker or CCB better than the other second line in terms of anti-anginal management. So the basic goal of using anti-anginal medication is to improve the symptoms And that based, of course, the patients being adherent to the medication, because we should not forget about this. If the patient, not adherent to the medication or not take the medication, of course, it will not work. And patients have to have as minimal side effects as possible. And look at the patient preference. I think that's again important. Patient having headache, patient having, you need to address that and use the right medication with minimal side effects. So medical treatment, symptomatic patient requires in every when you see the patient, and try to reassess the risk factors, and then the treatment strategy based on the risk assessment. And of course, this should be done as frequent as I mentioned in the guidelines. And these are, of course, the guidelines tell us about the stepwise. And I think we all learn nowadays that stepwise is maybe not appropriate, because that stepwise is not a dogma. We should take it based on the patient's heart rate, blood pressure, many other things as well. You can see here is you should not go with, wait until you try this to go with the medication which has got less side effects and better for patients as a strategy based on their characteristics and their preference. So optimal medical therapy, you hear this word all the time. And what we mean by optimal medical therapy, of course, that the one which control patients and patients stay adherent with minimal side effects. We should not just look at the drug itself, optimal dose. Need to look at all these aspects, and patient-tailored approach, I think, is very important, because that tells us, how to tackle patients based on their ejection fraction, heart rate, blood pressure, and otherwise, medication will be a waste of time. Patient, maybe you list in their list of medication, but they don't take it. If you don't tailor them as you tailor your clothes sometimes, as you can see. So 2013 to 2019, you can see the change happen in terms of the diagnosis. We stress ECG is out, CT is replaced that, and upgrade of the our medication here from 2B to 2A, which is it tells us that's important of this medication to be as you can see here 2A. You can see trimethoprim should be considered as a second-line therapy to reduce angina frequency and improve exercise tolerance in the subject who cannot tolerate or have contraindication to the medication like beta blocker, because they cannot. If you're going to go higher dose 5 or 7.5 on beta blocker like bisoprolol or nitrate, they're having side effects, then they stop other medications. You need to consider that, and that happens the more frequent you see your patients and you discuss with them. So basically, trimethoprim upgraded from less beneficial to more beneficial, and what I want to say here is this is one of the latest by our colleague Dr. Rosano. He likes angina management, and he does lots of awareness about it, and tells us that this medication trimethoprim actually in every place. Any patient whether have low blood pressure, high blood pressure, low heart rate, high heart rate, it works at micro and diabetes, chronic. So basically, a medication which is help you with the symptoms, patient tolerant with the side effects, have no problem with it, and adherent to it. So what do you want more than that? So basically, and take-home message that we learned from previous colleague saying about the disease moved from disease to syndrome, and this presentation of classic, what we heard about CCS is as low as 15%. If you're looking just for angina, you should look for other things like shortness of breath as well, and overall risk factors. And the numbers of the times you want to see the patients should be at least 4 times per year, and you need to tailor your medication to the patient's characteristics. And we learned that the trimethoprim moved from 2B to 2A. We should use more and more of this medication to optimize their medication. We should not prematurely intervene in terms of intervention before we optimize our medication. And the trimethoprim is a well-tolerated medication and well-established. And on that, thank you very much.
Thank you, Dr. Abdullah, for the excellent talk as usual. You raised lots of very important points, and I think one of the most important things is, like in heart failure, where we move to combination therapy very early. I think this is more the direction in coronary artery disease as well. And the algorithm that's presented by Professor Rosano is very interesting. Do you think that will lead to a change in the guidelines? And do we need to wait for the change in the guideline, or do we need to implement something like this from this moment?
Thank you very much, Dr. Juwairiya. You know, the guidelines, it depends where it's coming from. Is it European, American, ours? Lots of reasons for it, you know, and they're based on many things, actually. You know, we have a problem, you know, if you need to take consideration the patient number of medication, you don't want to increase number of medication. Of course, that's a problem. When you come to heart failure, to angina, they need multiple medication. I like the strategies. If we're able to bring these medication, which is a first line, second line, third line, bring them in a one tablet, make it easy for a patient to take it, I love it, you know. But as long as they are separate, as you see, the guidelines always emphasize to go with the one we have more data. But again, the data is old. Rosano is up to date, and I like his approach. And I think, I mean, from personal point of view, I've used this medication, different one of them. And again, it varies. It's very helpful. You know, you use the lower dose of beta, lower dose of calcium antagonist with this medication, you get the benefit. Yeah.
Abdullah, an excellent talk as usual. It puts a lot of comments and you know, nowadays also in the American Heart Association, they had what's known as 10 points for this card that's known atypical. No terminology called atypical anyway. It's called non-cardiac. Number two, European Americans say dyspnea is equivalent to angina. And this could be also for the audience is important nowadays, not only angina, it's dyspnea on mild effort. You put an important point regarding that there is no mortality benefit, but this is a symptomatic treatment. So do you think that we have beta blockers, have calcium channel blockers, who have nitrates? About the mortality, are you treating to prevent mortality, morbidity, or diminish morbidity, or symptom relief? I mean, quality of life, physical limitations, number of attacks. What do you think that you are giving the treatments? As Dr. J said, that we are in the era of combination therapy in atherosclerosis, in hypertension, in heart failure, and in ischemia. Maybe the same mechanism in the atrial dysfunction is the same with the four, so it could be a combination, patient-tailored approach. How do you explain what I said that now? The combination and the patient of mortality of the drugs.
Yeah, I mean, Dr. Mohammed Subhi, you're really raising a very important point. And regarding the mortality, we always talk about mortality. I mean, do you ask your patient, do you want to live longer with misery, or you want to have a nice life, you know, and I mean, I love to have, you know, quality on my years rather than the years on my, you know, just with a misery. So I think this medication, Dr. Beta blocker, calcium antagonist, I don't see they improve mortality in terms of for CCS, but we've seen it for the for the acute coronary syndrome, for that, yes. But for CCS, the data is lacking. So if I have a medication like tramazidine and others, you know, combine it with and I get a good quality of life, improve the symptoms. And you need the surgery, doctor. You don't need a surgery to improve their quality of life. As easy as that, you know.
Okay, and another point regarding the class 2. You said, I'm sorry, Karim, just to make this point, because you have one slide with the guidelines about the use of trimethadine or the second drugs like ranrosine or bradine. It's class 2, all of them class 2, and A in the second treatment, B if you have a selective or low heart rate, low blood pressure. How do you explain that this couldn't be class 1? I mean, you shouldn't give it from the beginning, except in some. It's class 2A and class 2B. Is it different for you in your real life to go for class 2 rather than class 1?
Wallahi, regarding this 2A, 2B, I am not, it's more political. I mean, I don't want to go to that area. Now, we always discuss this. Depends on how you interpret the data. That's why they put, 2A, 2B. For me, it's a patient in front of me, and I have 2A now with this medication. I will use it. I combine it. I mean, real life is like that, combined. That's what we do.
Kareem.
Dr. Sofik, Dr. Sofik, I have a question, please.
Sharif, we didn't see you. Okay.
Sorry. Thank you, Dr. Abdullah, for the elegant presentation as usual. Now we said the second line, we have the trimetazidine, the ranolazine, nicorandine, and the ivabradine. How do you select, or can you put a diagram when to choose each of them for any type of patient, or there is any preference for any patient for one of the classes, one of these drugs?
Yeah, I mean, the guidelines is clear, doctor. You saw it, it just give you which one to use. Ivabradine, where the heart rate is a certain number, the same with the trimazidine, if the patient's blood pressure, so and so. But I think, Rosano put it nicely for trimazidine. He put it everywhere. Yes. I like that one. And I have actually, from personal point of view, guidelines is there. But again, you don't forget your expertise. If you are in that field, you found it, and I found it very, very helpful. And rather me just listing what the guidelines says, and my experience tells me I am happy with this combination when I use it with the combination with lower dose of beta blocker, not the higher dose, so a patient can tolerate it.
I think, Sharif, for your questions, as Dr. Abdullah have one slide regarding the blood pressure and the heart rate. And this is an important slide that's showing that trimazidine in all, ranolazine also in all, but not ivabradine. Ivabradine not in low heart rate. This is the difference between the nicorandil is not in all. It's only in the high blood pressure. You know that some complication about the ulcers which we reported. So you have to be cautious with this kind of drug. Kareem, I think you have a question, Kareem. I looked.
Yes, thank you, Professor Abdullah, for a nice presentation. Actually, I have two questions regarding our subject today, which is the chronic coronary syndrome. The first one regarding the diagnostic modality for diagnosing the patient with chronic coronary syndrome. Do you have a diagnostic modality of choice, or you choose between diagnostic modality according to the patient clinical criteria? And the second one regarding, we now in the chronic coronary syndrome have the patients that are post-acute coronary syndrome or stabilized patient post-acute coronary syndrome, and we give them a beta blocker for a while. So for how long you would continue the beta blocker for the patient with post-acute coronary syndrome with normal ejection fraction?
What I do and what the guidelines say. That's I differ with the guidelines sometimes, but because this comes from experience. But I don't ask for everyone to do it, but this is what I do. In terms of sorry, what first question I forgot?
The diagnostic modality, yes.
Yeah, diagnostic modality, doctor. I mean, I love non-invasive imaging. I especially in the low to intermediate. I've been using CT a lot to, not to go for coronary angio. And it helped me a lot, actually, for calcium scoring, and also if I go for CT coronary angio. Stress ECG, I use it mainly later on for other aspect. Nuclear, I'm not, I know it's for intermediate to higher. I've been using, but again, it depends how you interpret that. It depends on your, the center you're at. And of course, coronary angiography. And the medication, beta blocker for how long? I depends, if patient don't like it, I stop it, I mean, I know I say to patient as long as he can take it, but if not, then I try to reduce the dose. I try to combine with, that's why it's important to, to start and tailor things according to the patient's preference, patient tolerance, patient side effects, all that.
Because the trials, the evidence goes with what you are saying. The beta blocker in the patient with post-acute coronary syndrome and normal ejection fraction after 1 year showed no benefit and no survival benefits. So it's not mandatory to continue beta blocker for this patient after 1 year of acute coronary syndrome event.
So Abdullah, do you have, as Dr. Sharif said, the quick question to you, we have now ranolazine, we have nicorandil, we have trimazidine, also we have ivabradine. Are there any precautions for using all of these 4 drugs? I mean, this drug has something like that. You have to be cautious, don't use it. And the others had another disadvantage, don't use it. because I think this is a more crucial point to use this. Not all these drugs can be used, except trimethoprim. I think, except there is no Parkinsonism and no motion disorders. This is the only disadvantage with the use of this drug. The other three drugs, in real life, what you're going to do.
Yeah, Doctor. Well, I don't like polypharmacy. I mean, this is my approach. I don't like polypharmacy, but if I can put this medication in one tablet, one pill, it's fine. Patient will not continue taking the medication. I try to use the ivabradine. Of course, the beta blocker is, is there, and heart rate is still high. I use ivabradine. There are many advantages of it. Trimethoprim, I use it all the time, and I have I've seen it. It's beautiful. Nicorandil, I don't have it in the country. I used to use it in UK.
Okay, I think maybe Nicorandil is very difficult to use, except in these ulcers. It's maybe only in patient no reflow. Regarding the Ranexa or it's ranolazine, it's very important to be cautious in patient drugs which increasing the QT, because this is a very important point in using this drug. Sometimes patient get, and also with some of the antibiotics and chemotherapeutic drugs, so we're very cautious with the clinical pharmacologist to say this can be used. But trimethoprim, there is no precaution except if a patient has a Parkinsonism or motion disorders. So this is a very safe drug. Then a political question to you, usually coming from different companies. Why you don't have FDA for trimethoprim?
Why you don't have FDA?
You have only European. Ranolazine have FDA and European. So why not didn't use? Do you have the answer of this question?
You remember metformin? Was it approved by FDA?
Yeah.
Metformin, one stage, remain years until they approve it. I mean, I don't know. I mean, ask the American.
Because Servier is not an American company; it's an European company. That's why they are afraid to use it. So we are using this since a long time. It's a very safe drug. Actually, the patient quality of life, as Dr. Sharif said, that yes, we noted this. Like the Entresto, for example, they said quality of life like SGLT2. I think we see nowadays in heart failure patient is improved quality of life because you have weapons to have two weapons in heart failure. I think this is a great weapon for using anti-angina. Thank you very much, Dr. Abdullah.